Definitely, shall I? Good morning, good afternoon, good evening, everyone. It's a privilege to be here as part of IAPD virtual, and I'm so excited to be here. And I can see that almost everyone who's on the platform enjoying a wide range of lectures. And it's an honor to introduce Professor Juan. He's a professor in the Department of Pediatric Dentistry at Indiana University School of Dentistry and attending at Riley Children's Hospital in Indianapolis, Indiana. Juan is a dentist and a physician from Javerina University at Bogota, Colombia. In 1999, Juan moved to the USA and attended the University of Iowa and the University of Pennsylvania, where he completed a fellowship and residency in radiology and oral medicine, respectively, in 2002 and 2004. In 2006, Juan completed a master in public health, and in 2011, a doctorate degree in public health, both with emphasis in epidemiology at the University of Kentucky College of Public Health. In 2008, Juan completed a residency program in dental public health at University of Texas Baylor College of Dentistry. Finally, Juan completed a residency program and a master in pediatric dentistry at the University of Kentucky in 2012. Juan is a board certified by the American Boards of Pediatric Dentistry, Oral Medicine, and Dental Public Health. He's an active member of the American Academy of Pediatric Dentistry, American Academy of Oral Medicine, American Academy of Oral and Maxillofacial Radiology, Indiana Dental Association, and American Dental Association. It's an honor to introduce you, Professor. And the title for the presentation is, Are X-rays Still an Option in Pediatric Dentistry? The digital podium is yours.
Well, I really want to thank you, Mutu. I really appreciate your introduction. And I want to send a big hug to everybody who is listening to this lecture, because I know we are attendees from all over the world. You may are in Africa, Asia, Europa, and here in the US, or in Latin America, or in any place in the world. Please receive a warm hello. I'm so excited with this meeting, and I'm so excited with this invitation. This is my favorite topic, and I honestly don't have any more words than big thank you to recognize your interest in radiation in pediatric dentistry. And to recognize that you are spending time away from your practice, from your family, from your friends, to spend about an hour with me. So a big thank you. I hope that you are going to learn. I hope that you can hear me. I hope that you can see the PowerPoint. And I just want to tell you, if something happened with the PowerPoint, we love each other, we hug each other, and I promise I will try to walk her up as quick as I can to get a different computer. But we need to be so thankful with IAPD and this amazing, pristine organization. And obviously, I want to thank you for the invitation. This is an honor for me. And I never imagined in my life that I will be speaking through a computer to all my colleagues around the world. Okay. So this is a very provocative title. Imagine, are X-rays still an option in pediatric dentistry? So you can guess from this title that I will go and discuss radiation in pediatric dentistry, how we can decrease the amount of radiation to the patients, which, as you know, our patients, pediatric patients, are the most radiation sensitive. So this lecture is going to take you from different topics, but at the end, I think so probably the most important take-home message is, yes, we need to use radiation in pediatric dentistry. We are still using radiation. We need radiation, but we need to be very sensitive to the use of radiation with kids. So that's kind of the bottom line, and we are going to expand that through this amazing webinar. So progress and challenge. That's my name. I had the fortune, the best job of my life. You know, the day that I accepted the position at Indiana University, really my life changed. I have been working here at IU and Riley Children's Hospital, which is the only pediatric dental hospital, pediatric hospital in the state of Indiana for the last 6 years. So it's the best years of my life. If you want to follow me on Instagram, I have an Instagram account and I place interesting otopathology and otoradiology cases in kids. So the question is, are x-rays still an option in pediatric dentistry? Well, the answer is yes. That's it. Conference is over. That's it. Yes, still, of course, it's still an option. So this lecture, if you decide to stay with me, if you decide to stay with me for the next 45 minutes or 50 minutes, I will expand that answer. Yes, x-rays is still an option in pediatric dentistry. Radiation is still an option. We just need to be a little bit more careful, and not because we are going to change what we are doing, but if we have a better understanding of what is the meaning of radiation, we probably are going to take the use of radiation more seriously, especially working with the little ones. So yes, still an option. So disclaimers, I don't have any financial conflict to disclose. Just briefly, I usually don't like to place slides about my family or trips or whatever, but this time I have a couple of slides, just 2 slides about my workplace and my hospital. So I work at Indiana University. I know some of you are from different places of the world. Indiana is a state located in the Midwest of the US. We are not too far, about 3 hours driving from Chicago, south of Chicago. And we are the #1 public university in the state of Indiana, 111,000 students in 7 different campuses across the state. We have about 19,000 students in graduate and professional programs, including our dental students and our residents. That's amazing, about 8,500 international students that I will guess how many of these 8,500 are in these days around us. Many of these students, obviously during these days, are probably outside overseas. We are 21,000 faculty and staff members. I feel very proud, a very diverse faculty. We are for 120 plus countries of the world. And last year, this university secured 680 millions in external funding. And this is my home, Indiana University, Riley Children's Hospital for Children. We are about 300 bed hospital located in downtown Indianapolis. And we are very proud, and I'm saying that in capital letters. If you are familiar with McDonald Dentistry for the Child and Adolescent, well, Dr. McDonald was a faculty here in Indiana for many, many years. He was the dean. And he died as probably 1 year after I came here. But I'm very proud to be working in the same department that Dr. McDonald worked for many, many years. That is the 10th edition of the textbook, and we are working in the 11th edition. So I'm sorry to tell you, but this lecture is not about, this lecture is not about radiographic interpretation. I would love to do that, but we are not going to talk about that. This lecture is not about common radiographic lesions in children. I can do that for hours, but we are not going to talk about that. So we are not going to review idiopathic bone sclerosis, OKC, or whatever. And this lecture is now, if you are looking for a new panoramic film machine, I am not going to tell you which one is better or which one you're supposed to get or which one is the ideal panoramic machine in pediatric dentistry. So this webinar is about, kind of review the essence of radiation in pediatric dentistry. We are also going to talk a little bit about other no-ionizing radiation alternatives that we have as a pediatric dentist. And we are going to navigate this lecture through a bunch of interesting topics away from the previous slide. So these are my goals. So after we complete, we are going to remember the basic concepts of radiation safety and protection. This is not a lecture about radiation physics. So we are not going to spend 6 hours looking at the electrons and how they hit the bone and whatever they happen with the electrons. We are going to understand how important it is to obtain good quality radiographs in the pediatric patient. We are also going to briefly go over the correct technology in the dental office. What is better, to use sensors or to use phosphoplates? And at the end, we are going to go over other non-ionizing radiation alternatives for the diagnosis of interproximal caries. I'm going to torture with my accent. I feel very proud to having an accent, even living in this country, which is a country who adopted myself in 2008. I'm originally from Colombia, but my accent helps because with my accent, you need to pay more attention to the slides. So here we go. Definitely in the last 20 years, we have a lot of progress in imaging in pediatric dentistry. We went from that picture that you can see on the left side, which is the old days when I was in dental school. I remember using that cone X-ray heads, which pretty much, you know, you really don't need to even, you can close your eyes and, you know, you really don't need to guess where is the film. You don't need to use any device, nothing, because that cone will send the radiation pretty much everywhere. And you can see the progress in the last 20 years. In these days, we have portable X-ray devices like the one that you see there. That is my hand holding one of the portable X-ray devices that we have. So we went from almost no collimation and it may be using higher radiation and using slow films to a lot more technology. So just in one slide, I just want to go over some of the progress, and then we are going to talk about that in more detail. So we have better equipment. Obviously, we have electronic digital radiology. We have better receptors. And we went from C speed to D speed. And I hope that in these days you are using either E or F speed if you are still using conventional films. And we have digital radiology, we have sensors, and we have phosphoroplates. Interesting about collimation, we went from no collimation and then to round collimation and then back to round collimation. And then we hope that after this webinar, you will get back to rectangular collimation. And I will show you why it's important to get back to rectangular collimation. So we are pretty much not using, unless you are still using conventional radiology, we move away from the dark room. And in these days, we use, obviously, the computer when we use digital radiology. And the selection criteria, we went from no selection criteria in the 1978, and then we went to ALARA. And in these days, we go to ALADA, which is as low as diagnostic if possible. Just one slide to give you kind of a nutshell of all the changes that we have been seeing in pediatric radiology in the last 20 years. So let me start with the first chapter of this webinar, which is radiation safety in the pediatric patient. You can take a nap. I will tell you if you want to close your eyes or you want to go and grab a cup of coffee, I will tell you when in this section you can do it. And then I will tell you, you need to come back to the critical slides. But you know, some of these slides you probably can skip it, but I need to do that so you have a better understanding about what is the truth about radiation. So radiation is too high or too low when we are working with children. So this is a summary, and we are going to review why we care about radiation in our little patients. I hope that you can see that chronometer that you see in the upper right corner. That means that I'm going to stop for 3 seconds. That means that you are going to think why you care about radiation in the little ones. I will give you 3 seconds so you think about that, and then I will move forward. Well, I hope that the answer was yes, I care. So when we talk about radiation, I always need to kind of take you away from sometimes misleading statements. For example, if you take a panoramic film in a 12-year-old patient, that is equivalent to 2 hours of looking at the sun. That's not true. But sometimes we use this way to compare, almost to minimize to zero the amount of radiation coming to a panoramic film. So I hope that you don't answer this question in these ways. If you have a mom or you have a dad who asks you, what is the amount of radiation for one panoramic film, or what is the amount of radiation for a periapical, hopefully your answer is not, oh, well, one panoramic film is about 2 hours walking outside, which is not the correct answer. How about CAM beam CT? We are going to briefly talk about CAM beam CT in pediatric dentistry, but I hope that if I ask you, what is the amount of radiation of one CAM beam CT? I will give you 3 seconds to think about that. And I hope that your answer is depends. Field of view, it really makes a huge impact on the amount of radiation. So if you are working in a bigger field of view, which is the area that you want to capture with the CAM beam CT, obviously the amount of radiation is probably more than 1 day. But if you are using a CAM beam CT in a small field of view that just will cover maybe the maxilla or the mandible, or even when just cover one side of the maxilla or one side of the mandible, maybe the amount of radiation is close to that. So really the amount of radiation of CAM beam CT depends on how big is the field of view. And finally, the next question is, it's true that if I use digital radiology in my office, the amount of radiation is 99% less than comparing with conventional films? I also hope that you know that the answer to that question, you who are listening to this webinar, you who are in Malaysia, Japan, Singapore, Latin America, I hope that you know that the answer to this question is not true. If you use digital radiology, that's not 99% less radiation. In fact, sometimes using digital radiology, you can end up providing more radiation than traditional radiology because retakes are easier. So you 5 times to get one image. So at the end, you may are giving to that little boy or little girl, you maybe are giving more radiation than using traditional radiology. So I want to mention the Alliance for Radiation Safety in Pediatric Imaging. I hope that you are familiar with that. This alliance was created a couple of years ago, more than a couple of years ago. They have a wonderful website. It's a website who was created by pediatric radiologists. And then with a couple of years after the alliance was created, pretty much all the oral health organizations joined the alliance, including the American Academy of Pediatric Dentistry. Basically, we recognize that when we work with children, we need to adjust the radiation dose when we are working with the most sensitive and vulnerable population to radiation. So they have an amazing website. The logo or the motto is one size doesn't fit all. That means that, you know, when working with children, understanding they are more sensitive to radiation, we need to be more careful when we work in the parameters of the X-ray unit, and we need to pay more attention when we are taking the film so we can avoid retakes. A couple of years ago, I was part of the alliance, and they asked me to write a brochure about what parents should know about radiation in pediatric dentistry. So I wrote 2 pages, which you can download this brochure from the Image Gently website, and you can give to the parents when they ask you, hey, doc, what is the truth about radiation? Do you really need to take a panoramic film? What is the amount of radiation of a panoramic film? So almost like an appetizer, I always like to use that picture of that girl. How old is she? You can see that the dentist was trying to obtain a panoramic film. So later on, we are going to talk about the criteria of panoramic films in pediatric dentistry. But just as an appetizer of this lecture, this girl was only 4-year-old. And when I asked the practitioner why the practitioner was interested to get a panoramic film at that age, the answer was, oh, because I just want to know if all the teeth are there. Now, you know, that in my opinion, just my opinion, I'm not representing here my job or whatever, but in my opinion, that's probably not a very strong justification to take a panoramic film in a 4-year-old. So, you know, radiation is part of the diagnostic process. And yes, of course, we need to use radiology. And as I said at the beginning, are still X-rays used in pediatric dentistry? Of course, because what happened is, even if you are the most accurate clinicians and you use an amazing loops, you know, we are still not really having the ability to look at interproximal caries. I know I'm a clinician as well. And sometimes when you have a big caries lesion interproximal, you can look through the enamel and you can see that shadow and you can almost guess that, yes, there is decay there, but definitely X-rays will uncover that sometimes to the naked eye is impossible to see. Now, outside dentistry, in the real world, there is concerns about the use of radiation in children. I will just show you a couple of examples of why there are some concerns outside dentistry. And the concerns are mainly, doctor, you really need to use radiation in children? That is coming from the economist, little and not often, please, which means, please, doc, if you are going to take X-rays in my son, please think twice. There is a website, WebMD, that they have a section that they title the section, Dental X-rays linked to brain tumors. Are dental X-rays linked to brain tumors? Radiation worries for children in dental chairs. Are dental X-rays dangerous? So it's a kind of outside us, an idea that we dentists, we take a lot of X-rays, especially with kids. And I will show you later on some data about that. So we really need to balance. If we need it, we need it, but we can, obviously, we are not going to abuse, and we are not going to retake 5 times just to get one. So let me go into what I call Dora the Exploradora. And when I use this, my residents here in Indiana, they get upset with me because they, oh, what did you mean Dora the Exploradora? Well, in about 5 minutes, I will tell you what you're supposed to know about radiation biology and physics. And I call that, you know, Dora the Exploradora. So what are X-rays? You probably remember what is X-rays from your days in dental school. So dental X-rays are coming from the electromagnetic radiation field. They have a great penetrating power, so they have the ability to go through the muscles and to go through the dentin and to go through the whatever. And X-rays are produced by the bombardment of a substance, usually it's a heavy metal, by a stream of high velocity electrons, usually in a vacuum tube, and the wavelength is usually less than 2 angstroms. So this is basically what is inside an X-ray machine. In one side, you generate electrons, and the electrons are going to hit the target, and the target is tungsten. And as soon as they hit the target, they generate X-ray photons who are going to be directed by the collimation through my patient. I just mentioned the electromagnetic spectrum, and I will put here a couple of arrows. You can see that they are coming. We have 2 red and 1 green, just to tell you that radiation belongs to the electromagnetic field. And as you move to the right side of this chart, you are going to find ultraviolet light, X-rays, and gamma rays. The difference between all these different forms of energy who belong to the electromagnetic spectrum is the size of the wavelength. So ultraviolet light, that's the size of the wavelength. X-rays, that's the size of the wavelength, and gamma rays, a lot more faster. Keep in mind that the neighbors of X-rays, gamma rays, and ultraviolet light are used, gamma rays are used to radiation oncology, so they are used to decrease the size of tumors. And then to the left side, ultraviolet light is used in these days. You probably, in the COVID time days, you know that ultraviolet light could be used to kill bacteria, including viruses. So X-rays, neighbors, are killers. One tumors, the other one bacteria. Are children more sensitive to radiation? Yes, absolutely. There is nobody who can dispute that. Kids are more sensitive. And the reason that kids are more sensitive is because they have more radiosensitive cells. They have cells with a high mitotic rate, those cells who undergo many future mitosis, and also they have more cells with a very primitive differentiation. There are plenty of articles, and I'm just going to pick up one. Pediatric exposure to ionizing radiation. This is an interesting article published in a journal with a high impact factor, the International Journal of Environmental Research and Public Health, that they discuss that kids are at greater risk for adults to developing cancer after being exposed to ionizing radiation. It doesn't mean, capital letters, it doesn't mean, be careful here, that if you take a radiation, you are going to, you are going to cause cancer. But cumulative effects, over time, we really don't know. And because the radiations in dentistry are low, it's even more difficult to try to connect dental radiation with tumors. And I don't think so we are going to see that never in our history. However, we know for sure that kids are more radiosensitive. Do we need to care about the scattered radiation? Scattered radiation is something that we need to keep in mind when we are going to take radiographs. So scattered radiation comes from when the X-rays hit my face or hit my teeth, or when the X-rays hit my glasses or whatever. 3 things can happen, especially when they hit tissues. So when the X-ray hit my muscles or whatever, 3 things are going to happen: cohering, scattering, photoelectric absorption, and Compton effect. The only one that I'm going just to say a few words is the third one, because the third one, interaction of the X-rays with the tissues, is the one who explains scattered radiation, which means, Dora the Exploradora, that some X-rays are not going to go through my face and hit the film. Some X-rays are going to bounce back, almost if you have a bunch of ping pong balls and you send the ping pong balls against the wall, some of the ping pong balls are going to get back to you. And that's what I mean with the scattered radiation. So you are going to be surprised about this. So a scattered radiation, the scattered photon, they travel in all directions. And 30% of the scattered photons formed during dental X-ray exposure, they exit the patient head. That means that even if you are placing the thyroid collar in your patient, there is a big possibility that some X-rays are going to hit the thyroid. Now, obviously, using the thyroid collar, you decrease the amount of X-rays who are going to hit the thyroid, but definitely, even with the X-ray collar or thyroid collar, some X-rays can potentially hit the thyroid. And so even if the proper radiation protection, scattered photons will hit different organs and tissues of the child. I know you are sitting there and saying, okay, I didn't know that this webinar was about radiation biology, radiation physics, scattered radiation. Yes, it's about that. Because if we really want to talk about our X-rays still using pediatric dentistry, we need to understand this. So one slide to finish to complicate your life. This slide is about radiation biology. And I am not going to explain this in detail. In a different webinar with more time, I will spend in this slide about 10 minutes, but here I'm going to spend about 20 seconds. Stochastic effect. What is the meaning of that? A stochastic effect is when radiation hit my face over and over and over and over time, there is some cumulative effect of radiation. That means if I take bite wings every 6 months, no matter what, even if the open spaces, I can put my face between the primary molars, but I take a bite wing every 6 months because whatever reason. So that means that the stochastic effects, that radiation will leave some effects in the cells who are affected by radiation. And that could be cumulative. Now, this is important. It will take 25 years, 35 years, because that cumulative effect will cause some palpable, visible changes in that organ who was hit multiple times. So that's a stochastic effect, which is always important to remember when you hit. So don't go now to get your coffee. The next 3 slides are critical in this webinar. So please come back and now look at the screens. So the next 3 slides are going to be a pretty important concept in something that we are going to talk later. The first thing is background radiation. So using background radiation is probably the best way that we use to compare the amount of radiation with the amount of radiation of one panoramic film or the amount of radiation of a periapical, compare with the background radiation daily that we are getting from the sun, from the earth, and from different things. So this can change because if you are in Nepal and you live high in the mountains, the amount of radiation that you receive per year is probably higher coming from the sun. But if you live in Orlando, Florida, probably the amount of radiation is not as higher if you live in Nepal. But for this webinar, I'm going to assume that the amount of background radiation per year is about 3.4 millisieverts. Forget about the millisieverts. That's the units that we use, you know, for this webinar. Imagine could be apples, whatever, 3.4. Again, if you live in high altitudes, maybe a little bit more than that. If you live in low altitudes, a little bit less than that. That 3.4 is coming from natural sources, the sun, terrestrial sources, and about 17% is coming from artificial radiation. Medical radiology, obviously more important than dental radiology, but artificial sources, when you add all the artificial sources, it's about 17%. So the amount of radiation, when you take a full mouth series, using round collimation, is about 22 days of background radiation. That's the amount of radiation that you are giving to the patient. If you take the same full mouth series using rectangular collimation, that's the reason that is so critical to, especially as a pediatric dentist, is extremely critical to use rectangular collimators. Look at the numbers. You go from 22 days of background radiation to 4 days of background radiation. If you take posterior bite wings, it's about half a day of background radiation. One panoramic film in a child is about 1 to 3 days of background radiation, depending on the unit that you are using. Cephalometric CEF or lateral scalp projection is about half a day to 1 day of background radiation. Obviously, if you take a CT, a computer tomography of the whole face, it's about 243 days of background radiation. Collimation in pediatric dentistry? Absolutely yes. I am a fanatic of collimation. Yes, I scratch my head and sometimes I get pretty upset because the no use of correct collimation sometimes will give you concats, and concats means you will need to retake. All these articles that I'm going to show you here are available for you. At the end, I will give you an email, and you can send me an email and I can share with you all the articles. This is an article that I published a couple of years ago, Radiation Safety and Protection in Pediatric Dentistry, how important is the use of rectangular collimators. Now, I know some of you are sitting, okay, give me a break. Are you telling me that I need to use rectangular collimators? Yes, but the problem is, if you use rectangular collimators without using the positional device, I know in some places they call that the X-ray positional device or XCP. What happens is you will get concats. You need to pay more attention. So if you decide to move into rectangular collimators, absolutely you need to use that. The last report of National Commission of Radiation Protection report, Radiation Protection in Dentistry, was published and available to the public in December of 2019. This is a publication that you must have, honestly. It's about $85, and it's an amazing, the title is Radiation Protection in Dentistry. And in a very easy to understand language, we'll go into everything that you need to follow to perform in a safe and correct in terms of radiation protection. In the page 21, radiation rectangular collimation of the X-ray beam shall be routinely used for periapical radiographs and bite wings. So I will invite you at this point of my webinar, if you are not using rectangular collimators, to really think seriously to use rectangular collimators. One of my heroes of radiation protection, Dr. Ludlow, he's a professor emeritus of the University of North Carolina. He actually put together this slide that you can see that there is a big difference between the area that you are going to provide radiation between using round collimation and rectangular collimation. Rectangular collimation, the reduction of the exposure area is about 55%. You can convert round collimation into rectangular collimation in the way that you are seeing in this sequence. Now, if you are going to convert between round collimation into rectangular collimation, you need to invite your staff members to a full vacation 1 week. And then at the last day, when everybody's happy, after 1 week for free, all your office members, you put everybody together at the lobby of the hotel and you say, well, it was a pleasure to invite you to a free week, free room, free drinks, free everything. But I have good news for everybody. We are going to switch to rectangular collimators. So you need to do that because otherwise they will feel bad to get upset with you. Because what happened is, if you switch to rectangular collimators, you really need to do some retraining. Otherwise, you can end up taking more radiographs because using rectangular collimators, you can get more concuts, especially if you don't use the XCP. But there is no question that rectangular collimators provide less radiation. The area that you are going to irradiate is less. This slide, at the end of this lecture, I will give you my email. So I'm not going to spend more than a minute in this slide. These are different rectangular collimators that you can adapt or you can kind of retrofit your X-ray unit. You can see some are more expensive than others. If you want to get my PowerPoint, you can get to this slide. And this is a picture of the different options that we have. But obviously, if you decide to move into rectangular collimators, you need to use an XCP or X-ray positional device. And obviously, in a 2-year-old, 3-year-old, sometimes it's difficult to do that. I'm a pediatric dentist, and I fully recognize that. Now let's go into the Dora the Exploradora of the image receptors. And which one is probably easier to use in pediatric dentistry. So I'm going back to the radiation protection publication in December of 2019. In the page 22, there is a statement, image receptors of a speed is slower than E-films shall not be used for intraoral radiology. So I hope that you are not doing that. I hope that if you are still using conventional radiology, I hope that the speed of the film that you are using is E or above, because obviously as more speed is in the conventional film, less radiation is needed to create an image. If you use some of the slower speed films, you probably are generating more radiation and giving more radiation to your patients that is necessary. This is a very interesting article. All these articles are from Dr. Ludlow, comparing what is the effect of the film speed and effective dose in intraoral imaging. And there is no question, you can see that the use of DSP film, look at the amount of radiation, which is the last bar on the right side, compare of the amount of radiation of using phosphoroplates or using a F-speed film. So what is the true? Remember I told you at the beginning, 99.9% that's not true. So you use digital radiology, you are now working at a 99% lead radiation. So the dose reduction comparing with F-speed film, so we are going to use F as the way to compare, using digital radiology is somewhere between 0 to 50%. However, I need to say that if you are using phosphoroplates in your office, the risk of higher exposure is a little bit more comparing with sensors. So it's not 99%. Now, you need to change the settings of the X-ray unit according to the system that you are using. Because what happened with digital radiology, you can continue using a high kilovoltage, but because you can adapt the contrast using the mouse of your computer, you may well feel like, okay, my films are too dark because you are using a high KB, and then I can light the films using my mouse. But the idea is to get a perfect film from the front using the correct KB according to the system that you are using. So unfortunately, using digital radiology, there is a tendency to create more images because clearly it's more easy to get an image. You don't need to go back to the dark room. You don't need to put the patient back. You just go and, oh, okay, I don't like it. I don't like it. This is often the question, and I will give you 3 seconds here. Which system is better in pediatric dentistry? You want to have phosphoroplates or you want to use sensors? And again, I will put the hat as a clinician because it's easy for me to be here in a webinar telling you, oh, you just need to use the sensor. But sometimes putting the sensors in the mouth of a child is, so, I mean, we as speakers, we need to be very careful because believe me, the PowerPoint can take everything. I can tell you, oh, no, you just need to go and use phosphoroplates or sensors. But one thing is to tell you that here, and second is a different thing is to be in the dental office. So I really don't want to answer this question right now. Yes, I will give you 3 seconds just to kind of, you can try to guess which system will be better, or maybe both systems will be the ideal settings in a pediatric practice. So we have different technologies, different size and shapes, different names. As you know, the sensors, the active area in the sensor is smaller than the conventional films. It's a little bit more bulky. And the reason is because you need to put in that sensor, you need to put the electronic substrate, you need to put the chip, you need to put the fiber optic, you need to do the scintillator screen, and then you need to cover that with a case. So they are clearly thicker. I think so nobody will disagree that. We have 3 different types of sensors. We have the charge couple device, or CCD. We have the complementary metal oxide semiconductors and the flat panel detectors. In these days, probably the majority of sensors that we are using are complementary metal oxide semiconductors. They are connected with a cable with the computer, so you expose that to radiation and you see the image immediately. On the other side, we have what we call indirect digital radiology. We have the phosphoroplates. Phosphoroplates come in different sizes. Sensors also come in different sizes. And the phosphoroplates, the characteristics of the films are very similar to the characteristics of the conventional film. Also, 100% is an active diagnostic surface area. The slices are coming with more information that I'm telling you in this webinar. Again, if you want to have my PowerPoint, you can get through the whole slide and you will get a little bit more of information. So conclusion, phosphoroplates are a little bit more easy to put in the mouth, yes. Now the image is not coming instantaneously, so you need to take the phosphoroplates, go to the processing station, put the phosphoroplate there, wait, and then you will see the image. So both systems. Honestly, and you know, phosphoroplates are a little bit easier, especially if you are working with the little ones. If you have a 3-year-old, 4-year-old, you know, obviously the sensor will get a little bit easier inside the patient mouth, comparing with the sensors who are a little bit more difficult to place in the mouth. I know some practices, they really master using the sensors, and that's fine. But in my own practice, we have a hybrid system. We have sensors and we have phosphoroplates. So in the little ones, we prefer to use phosphoroplates. How about if you compare spatial resolution between sensors and phosphoroplates? Pretty much the same. And you can go and read this if you want to have the PowerPoint. How about the detector latitude? Because a wide latitude of phosphoroplates and the automatic brightness and contrast optimization of the software, sometimes you can use a little bit more radiation than you really need it if you are using phosphoroplates. Take home message. If you are using phosphoroplates, you need to follow the indications of the software that you are using. So you set up the X-ray machine with the perfect KB because it's easier to go a little bit higher. How about in the detector sensitivity? Phosphoroplate systems for intraoral imaging dose reduction is about 50% less radiation compared with F-speed film. Generally speaking, sensors require a little bit less exposure than phosphoroplates. How about digital imaging for caries detection? So I thought the resolution of digital imaging is lower than conventional films. I know if you are I don't want to say an old dentist because I am 50, so I'm an old one. But if you are an old dentist, sometimes I hear this from my colleagues. Oh, the old days will be much better using conventional films. The old days with the conventional films, I will have a much better ability to detect interproximal caries. Well, you are right. That's right. In the old days, using conventional films, the resolution of conventional film is higher than the resolution of digital imaging. However, in digital imaging, we have some tools to enhance that imaging, and then that will increase our diagnostic accuracy, especially for incipient decay. So you are right when you complain that in the old days, conventional films will give you more resolution. You are right about that. But also we are right, the ones who use digital radiology, that using digital radiology, we have more tools that we can enhance the image, and that will increase our ability to see interproximal lesions. Interestingly, several studies found that magnification decreases the capabilities of detecting caries. You need to be careful when you magnify, because you can pixelate the image. If you are using a huge screen and you magnify that, sometimes the resolution, as you know, with conventional photography is the same, the resolution will go down. One of my favorite topics in radiation in children is the use of handheld X-ray systems. I think so. This is an excellent alternative. If you are using handheld X-ray systems in your office, you probably can confirm that. So handheld X-ray system, the question is always, oh, you know, I'm afraid to use that because it's going to be a lot of scatter radiation. Remember, scatter radiation, we talk about that. So sometimes some dental offices still a little bit scared about this because they are afraid that the operator will get a lot of radiation. So interesting enough, handheld X-ray systems, the dose of the handheld systems is significantly less of the wall-mounted X-ray system. So scattered radiation is less, almost to the point that is negligible. There is a lot more information in this slide. Again, I already told you last time that I'm going to say that if you want to have the PowerPoint, I can share with you the PowerPoint so you can go with this in more details. I will show you two studies that we performed here in Indiana using a pediatric phantom, which is a 12-year-old dummy, which I love with all my heart. We have been using the pediatric phantom for a bunch of studies. So the first study, we did it with the Nomad. And remember, I don't have any conflict to disclose. I'm not sponsored by any company here. I'm not getting any honorarium for anybody. This is an absolutely honor to be here. So we did a study with the pediatric, using the Nomad, which is one of the brand names. And we found that really the amount of scattered radiation is almost zero. And the amount of radiation that you deliver to the patient is less. And the other one, this is also a different system who is available in the market, at least here in the United States. I don't know in your countries. This is the X-ray to go. And the X-ray to go looks like a camera. And then we just submitted a publication to Paediatric Dentistry, and we are in the process of going through the reviewers' suggestions. So I hope, crossing the fingers, that the publication will be at the end accepted. So you will see in the Journal of Pediatric Dentistry soon. But we also did a project using the X-ray to go. And pretty much we confirmed the same that we found using the Nomad, that the amount of scattered radiation is significantly less compared with the wall-mounted devices. How about the thyroid projection in pediatric dentistry? That is also in the page 27 in the radiation protection. Absolutely, we need to protect the thyroid. Recently, a couple of months ago, maybe more than a couple of months ago, because it was before this COVID-19 hit our lives, it was an interesting article about you don't need to use any protection anymore, which is partially true. We may not need to use the whole lead apron, and I can expand that if maybe somebody wants a little bit more information in the QA section at the end of the webinar. But definitely we need to keep using the thyroid collar. Now, I prefer to use the whole protection because I like parents. I know it's more a perception, and something that I learned in my doctoral degree of epidemiology is perceptions make a big difference. Sometimes perceptions are not based in realities, but the perception of the parents is, oh, this guy is protecting my son to radiation, even if I know that I don't need to protect the whole body. So definitely the use of rectangular collimation in thyroid children is probably the best combination that we can get to decrease the amount of radiation in our patients. I don't like the thyroid collars who are attached to the lead apron. And also be careful, because sometimes you use the thyroid collar and you leave a space between the thyroid collar and the head of the patient that you can put your head. And that's not a way to protect. You need to make sure that the thyroid collar is against the patient neck. Now, in these days, we have two different thyroid collars. We have the no lead or lead free, and we have the lead aprons. They are pretty much equal in terms of protection. The only advantage of the lead-free X-ray aprons is they are a little bit more light, and if you believe that the conventional too heavy, and that may make a difference, that's fine. One of my favorite topics, I hope that you're still awake, is about pano-bite-wings. I have a problem with the pano-bite-wings because this is becoming popular for pediatric dentists, and sometimes, you know, the companies will mislead you and say, well, that's the future, to take pano-bite-wings. Because obviously when you take pano-bite-wings, you are moving away from the difficult patient. You know, you don't need to put the film inside, you just do it using like a conventional panoramic. But I will tell you, if you do that, two things. Number one, the ability of doing diagnosis of interproximal lesions is less. That's the first problem. And the second problem is you are going to give more radiation to the patient. And kids are more radiosensitive than adults. We published an article in the journal in Paediatric Dentistry, which is obviously the journal, the official journal publication of the American Academy of Pediatric Dentistry. We published this paper early 2020, before COVID. Before COVID. Oh my Lord, that changed our lives. And basically, we use the pediatric phantom and we compare the amount of radiation of doing pano bite wings and using conventional bite wings. And I will tell you the numbers, and you don't need to be a dentist. Even my mom will see that. If you use pano bite wings, the amount of radiation for our study, using two different brand names of panoramic machines, the OP30 and the Pro Max, is around 50 microsieverts, compared with 5 microsieverts if you use conventional films. Conclusion: there is a lot more radiation using the pano bite wings. You can get your conclusions by yourself. Now, in some patients, I need to be careful here. Don't say something mean in the QE. Yes, because you are talking as a faculty who is sitting all day long, sitting in a chair. I am not. I sit sometimes here in my office, but I'm in the clinic and I'm in private practice and I see patients. So sometimes the only option is the pano bite wing. I know that. Believe me, I know that. So let's go a little bit about guidelines of prescription of radiographs in children. Do you need to follow the guidelines? I will say yes. The guidelines are guidelines. And, you know, the last ones were for 2012, at least here in America, from the American Academy of Pediatric Dentistry. I know in your country may be different guidelines, but here, 2012, we are working actively in going and come with a new guidelines, hopefully in 2021. We published an article in 2018 in Pediatric Dentistry about dentists following the guidelines about taking a panoramic film. Some people ask me, what time is the ideal time to take a panoramic film in a child? If you follow the guidelines will tell you after the eruption of the first permanent teeth. After. But the guidelines doesn't say at. Listen to that. The guidelines say after, so that means that you can take it at the age of 7, 8, 9, whatever. The guidelines don't say, oh, you need to take the panoramic film at. Because if you take your panoramic film, the first panoramic film at, then you may end up taking panoramic films at the age of 5, because that's when you start to see the permanent mandibular incisors. So we look at that in our study, and we found that the majority of general dentists, they take the first panoramic film around the age of 5 to 6. And pediatric dentists, they take the first panoramic film around the age of 7 to 8. I belong more to the group of 7 to 8. At the end, nobody can tell you when, because the only one who can decide when to take a panoramic film is you. You need to have a justification for the imaging. That's the key. Patient selection criteria is the most significant factor that is going to influence the amount of radiation that we are going to provide to our patients. We need to have a justification. That means that we need to do the clinical exam of the child first before we prescribe radiographs. It's not the other way around. We prescribe the radiographs and then we look at the patient. Because if we do that, if we first prescribe radiographs, we may end up taking radiographs that we don't need it. I'm sure everybody's familiar with the guidelines from 2012 from the American Academy of Oral and Maxillofacial Radiology, American Academy of Pediatric Dentistry. Everybody mirrored the same guidelines. And this is what I mentioned before. So you have a new patient and it's a child with mixed dentition. You can take your first panoramic film after the eruption of the first permanent teeth. So I hope that you don't change that for at, because if you do that, you are going to take the first panoramic film too early. Now, if you have swelling, yes. You have a child like this after having a bike wreck? Of course. I mean, if you have a justification, you need to do it. How about CAM-beam CT in the young patient? Still, can we do that? Can we take a CAM-beam CT in a young patient? Are we going to burn the patient? Of course not. Yes, CAM-beam CT is indicated in the pediatric patient. Again, you need to follow the same. You need to have a guidelines for, and you need to have a clear justification. Like patients with syndromes, there is no question. However, I will tell you something interesting. We take for granted, we assume that if we have a 3D imaging, if we can see that child in 3D and move it up and down, and that will make us better dentists, but it's not true. Now, obviously, if you have a mesodent and the mesodent is in the middle of the cranial fossa, obviously you need to have a better view of that. However, at this point, listen this, at this point, there is little evidence that using 3D volumetric imaging over alternative radiographic examination will make us to do a better diagnosis. There is no evidence. There is little evidence about that. Now, implantology, absolutely. In endodontics, absolutely, there are indications. Craniofacial patients, absolutely. Oral surgery in some circumstances, absolutely. I'm not against CAM-beam CT. No way. I love it. If I see CAM-beam CT walking around, I will give a kiss. But I'm against getting a CAM-beam CT in all the patients. My academy, which I love it, the American Academy of Oral and Maxillofacial Radiology, there is a position statement published in 2013. And this is just coming from the position statement. There is no clear evidence to support the routine using of ionizing radiation in standard orthodontics. So there is no proof that if you use CAM-beam CT in every single child before doing ortho, you are going to get better outcomes. In some patients, again, and I want to say that in capital letter, again, in some patients, maybe yes, but that's not true that every single patient needs a CAM-beam CT. Now, if you are looking for impacted canines, of course. If you are looking for oral pathology and you want to know, and the surgeon wants to know from where to where need to do the resection, absolutely. We published a few years ago an article in Paediatric Dentistry, again, looking at doses of CAM-beam CT, because we want to compare the amount of using a limited field of view CAM-beam CT, and we specifically use the Kodak 9000 Carestream. That's the one that we have here at the dental school, so we use that. And we compare the amount of radiation of that and conventional panoramic films. So remember, the amount of radiation using a conventional panoramic film is about 6 to 20 microsieverts. A limited view CAM-beam CT of the mandible, 66 microsieverts. A limited CAM-beam CT of the maxilla, 63 microsieverts. There is more radiation when you do a CAM-beam CT. Now, if you need it, that's fine. But until, and I don't think so, we are going to see articles who are going to tell us, please, in every single patient, take a CAM-beam CT, because you are going to do a better diagnosis, your treatments are going to be better, your amalgams will look better, your composite will look better, so everybody will end up taking CAM-beam CT. But I don't think so we are going to see that day, because justification will steal the main sentence. To finish my webinar, if you're still around and you're still, so I hope that you get it, that the x-rays is still, yes, using pediatric dentistry, rectangular collimators, follow the guidelines, and have a justification. Use XCPs or X-ray positional devices. Have a hybrid system, maybe one sensor, and also use phosphoroplates. Phosphoroplates are going to be probably ideal in the little patient, and sensors in the more teenager patients who had a better tolerance. To finish this webinar, I have been speaking for 15 minutes, and I have about 5 more minutes. We are going to talk about other alternatives who are not ionizing radiation, which I have some of these options in my own private practice. So caries diagnosis, sometimes, you know, you have a patient like that, my mom can see the decay. I mean, you can, some patients, the decay is so big that you can smell and, wow, smell cavities. Wow, smell decay. I mean, you don't need to be a dentist. The patient opened the mouth and you see that big swimming pools. So you don't need to use radiation, really. I mean, you need to use it to see how deep it is, and you need to use it to whatever assess. It may be a bone. But sometimes we don't see anything, and we would like to have other options besides just using radiographs. So we have a couple of alternatives. We have radiation. We talk about that. We have laser fluorescence, and we have transillumination, and we have a couple of more options. So what is the radiology role for the detection of caries lesions? This sentence in yellow is probably the one that you know, and you need to keep that in mind. 40 to 60% of tooth decalcification is required to produce the radiographic image of caries. That means that radiographs are going to underestimate the actual size or how deep is the decay. That's common sense. We know that from first year dental school. When you are looking at a radiograph, that radiograph underestimates how big is the cavity in real life. We know that. That number, I think so the underestimate is not as high as 60%. I think so it's more closer to the 40%. So what is the diagnostic accuracy of dental x-ray? So to put this webinar, I look at a bunch of articles, And you can see that the sensitivity and specificity, it changed depending on many, many different factors. My point is, in general, there is a lower sensitivity and specificity values for enamel caries than for dentinal caries. That means that when the caries is in the enamel, radiographs are going to have less power to detect that. When the decay is already into the dentin, radiographs are going to have more specificity and more sensitivity to detect that. All the articles included in this slide are going to be available at the end if you want to have this webinar. Now, how about other imaging modalities available for the pediatric dentists who are not ionizing? And I'm proud user of some of these techniques in my office. So the number one is the camera. I think so the camera is more for patient education. Sometimes, and also, not just only for patient education, I need to say that it's also important for patient records. And sometimes, you know, when you are trying to explain to the parents, oh, there is decay, it's a lot easier when you put the camera inside and you show to the parents in the big screen, do you see that hole in the tooth? Well, that's the decay. But the camera is not going to be a difference from your eyes in terms of, unless you have a high resolution camera who will give you the opportunity to expand. But if you have loops, obviously the loops will compensate the magnification that you can get into the cameras. And the cameras are not going to help you with the interproximal decay. How about transillumination? I have transillumination in my office. Transillumination is a wonderful technique. At least in theory, this method allowed the dentist or the pediatric dentist to detect demineralization in all tooth surface and can be also used for inspecting the integrity of the tooth. Now, there is a learning curve. And with transillumination, will take some time to learn that learning curve. And the problem is, I will show you in a couple of slides. I'm sorry. With transillumination, what happens is the light will propagate around the tooth, and then the image is going to be sent to a computer for the analysis, and the computer will give you the images that you see here. This is the problem. And this is what you really want to know. The diagnostic accuracy of transillumination is wonderful, it's no ionizing radiation, but can I substitute radiation from transillumination? My answer is probably not. In some circumstances, when you have a patient who is a difficult gag reflex, or you have a question on the radiograph, the transillumination is going to complement that. But I don't think so we are to the point that we are going to replace dental radiation completely with transillumination. So what happened with transillumination, and I have the 3 seconds here, what is the meaning of a low specificity? That's one of the problems of transillumination. 3 seconds. What do you think is the problem? It's a low specificity when compared with conventional radiographs. Maybe more false positives. And what is the consequence of more false positives? The other day, I was working with a rep. I love him. He works with one of the bigger dental dealers here in the US. And he was telling me, Dr. Yepes, you need to use transillumination. This is the best system. You need to stop to use radiation and only use transillumination. And I told him, Scott, what is using transillumination? I may well ended up having more false positives. And he looked at me like, what? False positive? False, but it's positive. So I explained to him that the consequence of false positive is over-treatment. Because if you rely completely in that, the system may be telling you that it's decay when maybe it's a fracture. So you ended up providing treatment when maybe treatment at that point is not indicated. So the dark areas in the image can be attributed to a scatter and absorption of the light as passed through the demineralized enamel. And sometimes white spots can be mistaken as cavitation. The other system is laser fluorescence. The laser fluorescence is a little bit different from transillumination. Basically, it's a method of measuring the induced tooth fluorescence and quantitative tooth demineralization and the lesion severity. There are plenty of studies. The studies are cited at the end of this slide. But the sensitivity of laser fluorescence is about 67%, and the specificity is about 79%, which is a little bit higher than transillumination. Again, these are no ionizing techniques that maybe complement, or in some instance, probably the only option for us to really produce a diagnosis of an area that otherwise we are not going to have the ability to look with our eyes. So there are several studies that show with laser fluorescence higher sensitivities than Bite-Wings radiographs. But again, the problem with laser fluorescence is lower specificities. There is also the frequency domain photodermal radiometry and modulate luminescency. I can spend the whole day talking about this. I love the system. This is a system a little bit different from the laser fluorescence and different from transillumination for sure. This system has, and it's a little bit more complex, needs a learning curve, but this system you can go, and when you go to the commercial exhibition at different meetings, you will see this system will give you a little bit better sensitivity and specificities, but again, it's not radiation and requires a little bit more training. It will give you colors, and the colors will be related with the probability that you are going to have healthy tooth with decay or advanced caries. So that's the systems. So what we learned today, we learned that we are still using radiation with kids. We learned that we need to be more careful, which I'm sure you knew that before coming to this webinar. We knew how important it is to use rectangular collimators. We knew that it's not true that one panoramic film is 2 hours of walking outside. We learned about image gently. We learned a bunch of different articles that I will be more than happy to share. We learned that pano Bite-Wings are probably not pretty effective and very friendly in terms of radiation exposure to our patients. We learned how important it is to use rectangular collimation with XCP. We learned other modalities, no ionizing, that we can have as a complementary options in our office, transillumination, laser fluorescence. So we learned a lot of things in only 55 minutes. I hope that you learned. I hope that this webinar was productive. If you want to have my lecture, please, that's my email. You can send me an email. I will give you a couple of seconds if you want to copy my email. Remember my Instagram account, oral.diagnosis, oral period, diagnosis period, children period, YEPES. That's my Instagram account. If you want to follow me, and if you want to send me an email, and if you want to have this lecture, I will send you a PDF copy of the lecture so you can get, and also the article that I discuss here. To IAPD, a big thank you. This is an honor for me to be here. I hope that COVID will be out of our lives soon. So I will have the opportunity. I was in India with Dr. Muthu in November, and I have the best trip of my life going to Jaipur and going to Agra, and the hospitality in India was amazing. I was in Israel a couple of years ago, and I miss going and seeing my colleagues. I really miss that. Thank you so much. Any questions?
Yeah. Thank you, Prof, for an amazing, exciting session on radiology. So I think there are a couple of questions on the board here. Before I ask a question from there, I have a question from my side. I think you were a medical doctor first, then you did pathology, you did radiology, you did oral medicine radiology, you did pediatric dentistry, public health.
Such a crazy person.
No, do you have plans for orthodontics and endodontics? And that's all, only 2-3 specialties left. Do you have any plans?
Yes, I am going to start. But orthodontist, my brain will not give me enough neurons to be an orthodontist. My level of orthodontist comprehension is a Bannon loop. If you explain to me something more complicated than a Bannon loop, I don't get nothing. And so I don't know. But for sure, I don't have enough brain to be an orthodontist. To be an orthodontist, you need to be so smart, and I am not. So,
there's an interesting question here. The question is, during this pandemic, how do we evaluate the treatment outcomes of epexogenesis or epexification in young permanent teeth?
Yeah, I think so. Radiology. I forgot, but I was ready to just say a few words about radiology and the pandemic. I gave, I don't know how many webinars about the coronavirus, infection control, and maybe Dr. Muthu, you may attend one of my webinars about infection control. And I really, following the guidelines, radiology is not contraindicated during the COVID-19. Honestly, if you are wearing the N95 and you have a face mask over the N95 and you have the face shield, I know some of you maybe are thinking, well, radiographs are going to make the patient to produce more saliva. But if you have the protection I don't see why you cannot use radiation during the COVID pandemic that we are living right now. So, I mean, if you need to do it, you need to do it. The key is you need to have a justification. If you have the justification, you need, now taking a radiograph daily is probably not what you want to do, but if you have a justification, you need to do it.
Okay. Thank you, Prof. The next question is, guidelines recommend that regular OPG can be taken to assess the dental health of children, even when there are no symptoms or clinical complaints. How can that be justified, sir?
Well, you know, the justification is for growth and development. I'm not against, I mean, I take panoramic films in my office. I think so. The guideline will tell you, if you want to evaluate growth and development, if you want to evaluate the dentition, and if you want to have a whole view of the maxilla and mandible, panoramic films are appropriate to use. The question is, when is the time to do it? And that's what sometimes what I respectfully disagree with my colleagues, that they take panoramic films too early in patients who doesn't have any justification to do that too early. Like taking a panoramic film in a 3-year-old or a 4-year-old. Now you have a patient with swelling, you have a patient with pain, you have a patient after a car accident that is not biting in the way that's supposed to bite. Of course, you have a justification.
Okay, thank you, Prof. There's one last question. What will be the AI application? I think they mean artificial intelligence application in assisting in diagnosis.
I am just starting to work in that. We are going to start to use a software who was developed here by a friend of mine, and which the software will help you to identify pathology on radiographs. And that software is already mature. Some of you who are attending this webinar maybe are familiar with the name. I just don't want to get into any commercial complex here. But there is a software that you can play the software in front of a panoramic film or in front of a periepical, and the software will help you to look for pathology. We are going to work with children because the software is mainly for adult dentition. So the software is still having some problems when you have a child with primary dentition or when you have a child with mixed dentition. But definitely, artificial intelligence is not going to replace my brain, because maybe the software will tell me, you need to look at this area, but is my brain the one who is going to make the determination of leave it alone or maybe provide some treatment? Thank you so much. I really want to appreciate everybody. And remember, if you have questions or you want to have my PowerPoint, send me an email. Thank you so much.
Thank you, Prof. And thank you, IAPD Virtual. And it is an amazing session and a series of lectures. Very, very exciting to be here. Thank you very much once again.